bronchial obstruction syndrome. Actually, I believe today we don't need to explain the necessity of this topic in the era of COVID. And actually, after that, we will have the era of post-COVID patients, yes. And obviously, the frequency of respiratory disorders will grow up in nearest years. So actually, we have need to pay an attention for these patients. At first, I would like to explain that clinical pharmacology of certain drug classes is better to discuss on example of certain disease, if you wish, model disease. And obviously, for respiratory disorders, this model disease and most frequent disorder is bronchial asthma. Yes, on this picture, you can see international guidelines for bronchial asthma treatment, so-called GINA guidelines. I think everybody already knows the name and the title of these guidelines. GINA is translated as the Global Initiative for Asthma. And interesting that these guidelines are released by international organizations and under the protection of World Health Organization. This is significant because usual guidelines, cardiological, pulmonological, endocrinological, surgical guidelines are usually released by societies of another levels, European societies, cardiological societies of Europe, of Canada, of United States. Yes, but in this case, we have global guidelines. It underlines again the severity of this problem and actually pathways to solve this problem. At first, let's take a look at definition of bronchial asthma, and this definition will explain us actually our approaches in this disease treatment. Look at this, please. Asthma is a heterogeneous disease. So guidelines underline that today asthma, bronchial asthma, is not one single diagnosis. It contains varieties of disorders characterized by one single pathogenesis. And all of these disorders actually have one single common pathogenesis. This single common pathogenesis is so-called chronic airway inflammation. So let's underline that this is our aim of treatment in bronchial asthma patients. If you act on this inflammation, you can significantly change the pathogenesis and potentially you can improve the prognosis. At second, this definition underlines that asthma is not only allergic disease. Yes, previously we assumed that asthma can be only allergic, but later investigations show us that asthma can be non-allergic, it can be combined, it can have another forms in accordance to international diseases classification. That is why it is heterogeneous disease. And heterogeneous disease of this character of this disease means that we need to find different approaches in this disease treatment. So what else is written in the official definition? Asthma is defined by the history of respiratory symptoms, such as wheeze, shortness of breath, chest tightness, and cough. So the key word in this case is history. So when this person, a patient with bronchial asthma visits you, he can be absolutely fine. And actually, that is why I asked you if you are fine today. So they are also fine. They feel nothing, but actually, during the onset of bronchial asthma, they are not okay. They are not fine, and actually, these respiratory symptoms are present. For us, of course, sometimes it makes the differential diagnosis difficult. Just imagine a case when you are visited by a patient with one single respiratory symptom, such as dyspnea, and the symptom is absent during this certain moment of time. So your aim is to make differential diagnosis, and only history of these symptoms can help you. It is possible because all of these symptoms vary over time and intensity. And what is the reason of this variability? It is also explained in the definition. The reason of this variability is variable expiratory airflow limitation. Variable expiratory airflow limitation underlines that potentially the most of pathogenic factors in patients of bronchial asthma can be reversible, and actually depends on us if the symptoms become better or we receive the worsening of symptoms. So main conclusion from this definition is the presence of airway inflammation, and this presence of airway inflammation is variable, and our aim is to act on this inflammation. Of course, the most frequent variant of bronchial asthma is allergic variant. And that is why I would like to remind you general principles of pathogenesis understanding in allergic reaction. It is very important because our further conversation about the treatment of bronchial asthma will directly explain the use of certain drug classes, because the most of them will have direct action on this pathogenesis of allergic reaction. On this picture, you can see events happening during first allergen exposure. Yes, so this is not allergic reaction itself, if you wish. This is so-called sensibilization after first allergen exposure. Yes, how does it happen? At first, we have an invasion of antigen into a human's organism, and the antigen-presenting cell, usually this cell is macrophage. Macrophage process the so-called intruder, so it finds this antigen, if you wish, digests, destroys, processes this allergen, and the aim of these changes actually is to represent, to show, to present this antigen for another cells. So a macrophage or another antigen presenting cell expresses particles of this antigen on the surface of cellular membrane. After that, antigen-presenting cell attracts another cells. It liberates factors of intracellular cooperation and attracts another cells to find these particles of antigen. Usually, these cells are T helpers. T helpers. And in cooperation with main histocompatibility complex, it is also written on this picture, T helpers receive an information about this antigen, and the T helpers themselves invite B lymphocytes or B cells into this focus of allergic reaction. Already on this point of time, we can use the term of inflammation, but it is better to say aseptical inflammation, because actually in these patients we don't have any infectious agent, viral infection or bacterial infection. Potentially they can be present, but this is not infectious inflammation as at all. So they can be used only as triggers for allergic response, but not for classical immune reaction. I remind you that allergic reaction itself is a perverted reaction of immune system for intrusion, invasion of antigen. After that, B lymphocytes are differentiated into two clones of cells. First clone name is a plasma cell. So these cells are trained and differentiated to produce antibodies. Yes, these particles are antibodies. Another kind of clone of cells is so-called clone of memory B cells, and these memory cells will memorize information about this antigen forever. That is why a person, an individual, can receive allergic reaction even years later after initial contact with the antigen. So let's conclude. Sensibilization gives us actually the production of antibodies, and these antibodies are directed to be connected with the antigen. So this is perverted reaction, abnormal reaction of immune system, because we receive wrong antibodies. Everybody knows that in first type allergic reaction, we receive antibodies from kind E instead of G and instead of M. And IgE production is the reason of abnormal course of this reaction. Next time, after secondary allergen exposure, it has a place minimum 2 weeks after and later after first allergen contact, actually allergic reaction itself has a place. Officially, it is assumed that allergic reaction has three main phases. First phase of allergic reaction is called as pathoimmune phase. During this phase, our allergen finds IgE again, and we receive the complexin, the complex of antigen and antibody. This is abnormal reaction because abnormal antibodies participate in this reaction. That is why we use the term pathoimmune phase. This is pathological but immunological phase of allergic reaction. Second phase of allergic reaction is called pathochemical. The complex of antigen antibody is adsorbed on the surface of mast cells, so-called sensitized mast cells, or another cells responsible for allergic reaction, and these contact with the mast cells liberate biological molecules, so-called mediators of allergic reactions. What are these molecules? At first, this is histamine, serotonin, and leukotrienes. Histamine, as far as you know, is well-known target of antihistamine drugs action. But frankly speaking, in bronchial asthma, the use of antihistamine drugs is complicated. From one side, it is not effective enough. From another side, it can be related with significant side effects. That is why in daily practice, the use of antihistamines in the treatment of bronchial asthma is not recommended. It is possible. The position of this drug class is present in clinical guidelines, I mean in GINA guidelines, but for routine practice is not recommended to use antihistamines in the treatment of bronchial asthma. Second molecule produced on this step is serotonin. Serotonin is potentially good aim of treatment, but it cannot be used too, because serotonin, as far as you know, is a mediator of central nervous system. And action on this mediator is significantly related with potential side effects on this system. That is why in clinical practice, we don't use this pathway too. Third molecules, and actually third kind of molecules produced on this phase of allergic reaction are leukotrienes. Leukotrienes are metabolites of arachidonic acid, because arachidonic acid is destroyed into leukotrienes by the enzyme which is called lipoxygenase. Leukotrienes are possible to act on, and actually we can use anti-leukotriene drugs or leukotriene receptor antagonists to act on these mediators. So this is so-called pathochemical phase, because all of these molecules, histamine, serotonin, leukotrienes, are actually chemistry. Third phase of allergic reaction, so-called pathophysiological phase, is related with influence of these substances on organs and tissues. And the result of this action, of this influence, is directly depends on tissue we have a deal with. So if we have a deal with the muscles, we receive muscular contraction, and in bronchi, it means bronchospasm. Yes, these biological molecules can change the condition of blood vessels, of mucous glands, of platelets, of nervous endings, and another immune cells. So all of these actions actually lead to the formation of classical allergic reaction signs. And the signs, again, directly depend on the location of this allergic reaction. It can be a local reaction, such as atopic dermatitis, atopic conjunctivitis, atopic sinusitis, atopic rhinitis, and it can be bronchial asthma, and in some more difficult forms, we can receive even generalized reactions such as anaphylaxis, Quincke's edema, or something else. So let's conclude. The pathogenesis of allergic reaction explains us what to do and how to do, how to have a deal with drugs acting on bronchial conduction and acting on the pathogenesis of allergic reactions. We need to explain that allergic reaction and any inflammatory reaction in bronchi has some specifics. These specifics are described in the literature and in GINA guidelines as so-called bronchial obstruction syndrome. Frankly speaking, the term of obstruction itself is not very precise, because in translation from from native language, obstruction means the blockage. But the picture, morphological picture, functional picture of bronchial tree is much more wider than blockage of bronchi itself. So today, scientists founded 4 main components of broncho-obstructive syndrome printed on this picture. So let's take a look. First component is bronchospasm. So actually it means the spasm of left muscles described on previous picture, yes, and this spasm, of course, increases the resistance of bronchial tree and reduces gases exchange possibilities. Second component, and very important component, is edema of bronchial wall, mucosal edema. This edema obviously reduces the lumen of bronchial tree and also participates in bronchial obstruction. Next component, and very important component of bronchial obstruction syndrome, is isolation of viscous secretion and obstruction of the bronchi. In the literature, you can find the term which directly explains this change. This term is dyschrenia. Actually, it means abnormal activity of bronchial glands. I remind you that bronchial glands have this important function, the production of mucus secretion, and this secretion becomes glass-like. So this is abnormal exocrine function of bronchial glands. And actually, this certain component participates in the blockage of bronchial tree. Last component, but for me is the most important component of bronchial obstruction syndrome, is a sclerotic change. So sclerotic changes in bronchial tree are very important for the progression of bronchial disorders and very important for the prognosis of our patients. Why is it so important, and how to explain that? Let's take a look at all of these components again. We can find that some of them are reversible, and actually that is why bronchial asthma is variable in time and intensity. Bronchospasm, obviously it is reversible. Mucosal edema, it is reversible. Dyschrenia and abnormal sputum, of course it can be reversible too. But let's discuss sclerotic changes. Obviously, sclerotic changes cannot be reversible. Yes, and these irreversible changes of bronchial tree mean that one day your patient develops complications of bronchial asthma, and these complications can become independent reasons of this patient's death. Just imagine a patient with sclerotic changes in bronchial wall. At first, gases exchange becomes ineffective. And on later stages of bronchial wall fibrosis, it means respiratory insufficiency, respiratory failure. And it can be already the reason of this patient's death unless they die during asthmatic onset itself. Second pathogenetic mechanism is pulmonary hypertension, which has a place in patients with severe bronchial wall changes. And in this case, pulmonary hypertension causes changes in pulmonary circulation, abnormalities of right ventricle structure, right ventricle hypertrophy and enlargement, and later your patient will receive chronic heart failure. And this is next reason of their death, the worsening of heart failure. So let's conclude, sclerotic changes are pathogenetic changes which actually are main reasons of patients' mortality. And our aim is to act on these changes to prevent these abnormalities because it can significantly improve the prognosis. Let's discuss what is the reason of these changes. Obviously, that bronchial tree with persistent present allergic or non-allergic inflammation is a focus of immune cells activity. But immune cells are also not endless. One day they have to die. And this programmed cellular death has a name of apoptosis. And actually it means one day all of this bronchial tree will look like cemetery. And it will be replaced by connective tissue. This is normal course of history. If an organ has chronic inflammation, later this inflammation is replaced by connective tissue. What is the cell participating in this reaction? Actually, this cell is not directly related with the bronchial abnormalities. This cell is fibroblast. Everybody knows that fibroblasts are responsible for connective tissue formation and the progression of fibrosis. So this is very important conclusion that if we want to act on the pathogenesis of bronchial asthma, we will need to prevent excessive activity of fibroblasts and to inhibit them in order to prevent bronchial wall fibrosis, which is negative for the prognosis in patients with bronchial asthma. So these general considerations are already enough to understand how to use and what to use in patients with a bronchial asthma or another respiratory disorders. On this picture, you can see main drug classes used in patients with bronchial asthma. And actually, these drug classes can be divided at first into bronchodilators. These bronchodilators are used to dilate bronchial tree to relieve or to prevent asthmatic onsets, and they are used to act on variable and reversible components of bronchial obstruction syndrome. Bronchodilators include, at first, and the most frequent drug class used for this purpose is a class of adrenergic receptor agonists or stimulants. Later we will discuss them. Second drug class is a class of bronchospasm inhibitors. Another name of this class is the name of selective M-cholineolytics. Third variant of this bronchodilator treatment is the use of phosphodiesterase inhibitors, also called methylxanthine derivatives. So let's conclude. Among bronchodilating drug classes, we have three main classes: adrenergic receptor agonists, selective M-cholineolytics, and methylxanthine derivatives. All of them can be used in patients with both bronchial asthma and COPD, but the choice of these drugs is different in these disorders, and later we will understand how to make this choice. Second group of drugs used in bronchial asthma is group of anti-inflammatory drugs. Anti-inflammatory drugs suppress this chronic aseptical airways inflammation present in the most of patients with bronchial asthma and COPD. What drug classes belong to these classes? Mast cell membrane stabilizers. A very old and obsolete drug class. I would like to say that today clinical guidelines don't recommend to use this drug class, and later we will not discuss them. The reason is not their safety, the reason is their efficacy. Unfortunately, the level of efficacy is not enough for daily practice. It was shown in clinical studies. That is why today is not recommended to use mast cell stabilizers in daily practice. And only selected patients can take these drugs in additional indications, or if you additionally want to improve the efficacy of maintenance treatment. Next drug class, anti-leukotriene drugs. Anti-leukotriene drugs are actually drugs acting on leukotrienes, mediators of allergic reactions. Yes, we already discussed these leukotrienes are liberated from mast cells during petrochemical phase of allergic reaction. Corticosteroid hormones. If you want, this is main drug class among anti-inflammatory today, and this is the most important drug class in daily treatment of bronchial asthma. New drug class, which is also popular today, but in the treatment of COPD, is class of selective phosphodiesterase type 4 inhibitors. So this drug class has particular anti-inflammatory effect. And the place of this drug in bronchial asthma is absent. Yes, so this drug class is used in COPD patients. And of course, recent clinical researches and the recent successes of pharmaceutical industry gave us a variety of monoclonal antibodies. And today we invented monoclonal antibodies for the treatment of bronchial asthma too. Classification of bronchial acting drugs also contains combined forms, combined drugs, and usually these combined drugs contain two main representatives, one representative from bronchodilators and one representative from anti-inflammatory drugs. Sometimes these drugs can contain, these combined forms can contain two bronchodilator drugs together. Okay, so let's take a look at main classifications and main positions of certain representatives of these classes. Traditionally, we start with adrenergic receptor agonists or stimulants because they were very popular before and they are still very popular today. This is general classification. We need to pay an attention on so-called selective beta-2 adrenergic receptor agonists, because non-selective drugs such as adrenaline, ephedrine, orthoprenaline, isoprenaline are never used in daily practice, and sometimes doctors use them only in instant cases, only in severe cases in environment of intensive care units or resuscitation departments. In daily practice, for daily use, of course, we use beta-2 adrenergic receptor agonists. I remind you from usual life from basic pharmacology, we have two main subclasses of beta-2 adrenergic receptor agonists, so-called short-acting beta agonists, and it is even better to say fast-acting drugs. So we use them not because they are short-acting, we use them because they are fast-acting. The abbreviation for this subclass is SEBA, short-acting beta agonists. So short-acting beta agonists are represented by three main drugs: terbutaline, phenytosterol, and well-known salbutamol. So these drugs have duration of action only for 6 hours maximally. So this is their pharmacodynamics. That is why main aim of their use is fast action, because 6 hours of action obviously does not cover 24 hours interval. Second variant of beta-2 adrenergic receptor agonists are long-acting drugs, so-called LEBA, long-acting beta agonists. Colleagues, I explain you this classification so thoroughly because later we will discuss general algorithm of bronchial asthma treatment, and this general algorithm will contain all these drugs and will contain all of these abbreviations. That is why we need to memorize this abbreviation right now. So long-acting beta agonists are divided into so-called inhalation forms and tablet forms. Tablet forms are very rare in real practice, in routine practice, and of course, the use of inhalation forms is very, very important and preferable. Inhalation forms used before and classical inhalation forms of LEBA are inhalers of formoterol and salmeterol. But you should know that latest years we received new drugs from this subclass, from subclass of LABA, such as indacaterol, vilanterol, and olodaterol. On your local pharmaceutical market, you can find another representatives of these long-acting beta agonists. But on this picture, you can see this subclass has a name of ultra-LABA. And in the literature, you can find this term. The term ultra-LABA means these drugs have the duration of action close to 24 hours. Usual LABA long-acting beta agonists act only 12 hours. Ultra-LABA act 24 hours. This is significant difference. Obviously, in case of prophylaxis, the use of these drugs will have some advantages. So, what is the mechanism of beta-2 agonist action? The main action is directed on so-called cyclooxygenase system. It destroys adenosine 3-phosphate into monophosphate, and actually it has direct bronchodilation on fat muscles in bronchi. But today some pleiotropic effects of beta-2 agonists are described. Pleiotropic are additional effects, potential benefits from these drugs classes use, such as mast cells mediators release reduction, plasma exudation reduction, cholinergic neurotransmission worsening, mucociliary clearance improvement, and surfactant synthesis improvement. So all of these components make the use of beta-2 agonists preferable in varieties of cases, and that is why maybe today beta-2 agonists are the most popular bronchodilating drugs from these subclasses. Beta-2 agonists have different indications in different clinical cases. Yes, so if you wish to use them as relievers, yes, so drugs used to relieve asthmatic onsets, you should use short-acting beta agonists. And well-known reliever among them is salbutamol, phenytoterol, these drugs. So main indication for SABA, short-acting beta agonists, is either relief of acute asthma symptoms, or please pay attention, another indication is so-called situational prevention of bronchospasm. Situational prevention of bronchospasm means that you can use them directly before potential asthmatic onset. When your patient knows that he has these onsets during allergen exposure, and he has to have a deal with this allergen exposure right now. For example, he has to went out outdoors from his home, and he will have a contact with a specific herb which causes his symptoms. Or maybe he knows that he has exercise-induced bronchial asthma, and right now he has to perform this physical exertion. In this case, situational prophylaxis with short-acting beta agonist is possible, so he can take it before potential asthmatic attack, asthmatic onset. Long-acting beta agonists and ultra-long-acting beta agonists are used for prevention of symptoms. They cannot be used particularly in the treatment of symptoms because their efficacy is delayed. So it starts only 15-30 minutes later after intake. Obviously, the use of them for relief of asthmatic onsets is not effective. It is too late. That is why we divide drugs into relievers, and actually short-acting beta agonists are classical relievers, and we have controllers of symptoms. Yes, they are used for prevention of symptoms and exacerbations. And classical example is the use of long-acting beta agonists. How to make a correct dosage of beta agonists? This is absolutely simple. We know that short-acting beta agonists work 6 hours. We know this from the classification. So maximally, we can use them 4 times a day. Every inhalation, maximum 2 puffs. So it means 8 puffs per day. Long-acting beta agonists work 12 hours a day. So it means we use them twice daily. 2 inhalations maybe every time. So we receive 4 puffs a day maximum. Ultra long acting beta agonists, as we decided, work 24 hours a day. So we use them once daily, 1 maybe 2 inhalations a day. If a certain drug has another delivery method, and today we have varieties of inhalers with improved release, in this case, you should just open drug label attached to this drug, and actually you will find the method of this drug use. So you just need to check drug labels. Let's take a look at the specifics of some certain long-acting beta agonists features. We need to know that we already decided drugs into short-acting and long-acting, but some of them are exclusions from this rule. For example, in the world of long-acting beta agonists, we have 2 of these exclusions, such as formoterol and indacaterol. These drugs have both fast and long action. So what does it mean? Potentially, we can use them for both prevention and for the relief of bronchospasm. And particularly, we need to discuss it about formoterol, because today clinical guidelines for bronchial asthma treatment are based on this position and on this possibility to use formoterol for both prevention of symptoms as long-acting beta agonist and for relief of symptoms, since it is fast-acting. Next drug class, which is also very popular, maybe less popular in bronchial asthma than beta-2 agonists, but more popular in COPD than beta agonists. This is a class of muscarinic antagonists or M-cholinergic blockers. The parent of these drugs is atropine. And today, muscarinic antagonists are quaternary derivatives of atropine. So they actually already had 4 generations to find the best drugs in the treatment of respiratory disorders. Today, the most of them are given by aerosol inhalations. Main advantages of their use is absence of diffusions into the blood, so they have very low bioavailability. They are not absorbed into systemic circulation, which means the minimum of side effects occurrence. They do not enter central nervous system, and this is also their advantage. On this slide, you can see key representatives of muscarinic antagonists, but we should know they have different duration of action, same as beta agonists, and they have different place in the treatment of respiratory disorders. So 3 classical drugs which were previously very popular and they're still present on pharmaceutical market are ipratropium bromide, oxytropium bromide, and tiotropium bromide. Today in daily practice, maybe only tiotropium bromide is very popular because it is long acting. Newly invented drugs are glycopyrronium bromide, umeclidinium bromide, and eclidinium bromide. These drugs were introduced into clinical practice within last years, but they have some advantages in the treatment, and that is why today they are very popular both in monotherapeutic forms when an inhaler contains only 1 drug, and even more important, in combinations when 1 single inhaler contains antimuscarinic drug with another drug class. What should we know about muscarinic antagonists use in daily practice? You need to know that the onset of action for these drugs is at minimum 15 minutes. So we can make very simple conclusion. They are not very good drugs for prevention of asthmatic onsets. 15 minutes is already very long time, and obviously this is not comfortable for your patient to have asthmatic onset within 15 minutes until he receives the effect of ampoulinolytic. The maximum of action for some of them is 1.5 hours, but the duration of action directly depends on certain drugs. So that is why, for example, ipratropium bromide is not popular today. It is short-acting. Oxytropium bromide has 12 hours of action maximum. Eclidinium bromide too. It has 12 hours of action. So what drugs have a maximum of duration? These drugs are tiotropium, glycopyrronium, and imiclidinium bromide. So these three drugs are the most popular on pharmaceutical markets all around the world and on pharmaceutical markets in your countries too. So let's conclude. Today is better to use antimuscarinic drugs for the prevention of symptoms, for control of symptoms, but not for their relief, since they have delayed onset of action. And if we use them for prevention of symptoms, obviously it would be better to use long-acting antimuscarinic drugs such as tiotropium, glycopyrronium, umiclidinium, and we call them LAMA. Yes, long-acting muscarinic antagonists. One single exclusion is in this rule is the use of glycopyrronium. In clinical studies was shown that the bronchodilating effect of this drug occurs already after 4-6 minutes. So potentially this drug can be used in patients for relief of asthmatic onsets together with the prevention. And for me, this possibility can be used if your patient either doesn't have another inhaler with him, or he has an allergic reaction for the use of beta adrenergic receptor agonists. Next drug class we need to discuss among bronchodilating drugs is a class of methylxanthines. Clinical classification and the classification in accordance to pathways of pharmacokinetics divide them into parenteral, euphyllene, actually it is water-soluble form of theophylline, and oral forms of methylxanthines, theophylline, theotard, theopec, theobilong, and another prolonged form of methylxanthines. So first conclusion from this classification is the absence of inhaled forms. This is already disadvantage because the absence of inhaled form means varieties of side effects. The mechanism of phosphodiesterase inhibitors action is inhibition of this enzyme, which gives actually bronchodilating action and the inhibition of biologically active substances release. So they combine bronchodilative action with mast cell stabilizing action. Another action is stimulation of mucociliary transport. But we need to say that all of these effects are related with varieties of side effects. That is why today we use methylxanthines only in specific cases. Oral forms are used sometimes in prevention of asthma symptoms, but you should be ready to receive side effects, cardiac side effects, hypotension, tachycardia, prolongation of antiarrhythmias, gastrointestinal side effects, diarrhea, nausea, vomiting, neurological side effects, headache, tremor, convulsions. Obviously, this is not good for our patients. And these side effects presence make the use of these drugs from one side unsafe, from another side, these drugs are not very effective. So today, the place of these drugs actually is the use of parenteral forms when we use euphyllene, for example, for relief of asthma symptoms. So let's make a conclusion. Right now, we discussed main drug classes used for bronchospasm relief. These are beta agonists, muscarinic receptor antagonists, and methylxanthines. Let's have a break, maybe 10 minutes. And after this break, we will discuss drug classes used with anti-inflammatory action, and we will discuss general algorithms of treatment. Let's have a break, please.